Bismillah ar-Rahman ar-Rahim. Hello, everybody. Welcome again to my new episode with my friends. Really, it's honor to me to present one of the knights of digital dentistry, my old friend, Dr. Mahmoud Azzat. Hello, Dr. Mahmoud. How are you?
Hello, Dr. Wala. Thank you very much for inviting me to this great show that you're doing, Talk with Wala, on the Dentalinium Group. I'd like to thank you first, of course, for all the activities you've been doing since we've been staying at home. You've been keeping millions of dentists busy, and this is not something easy to do, and you're doing it at the cost of your time, and with you're doing a lot of valuable work actually for tons of dentists worldwide. I think that we should all thank you for giving all of us as speakers the opportunity to be on your platform, and also thank all the dentists should be thanking you for keeping them busy and educating them through these hard times, because actually this is one of the best things that you can make best of your time while we're all staying at home. So I'd like to thank you first for setting this up.
Thank you very much, Doctor. Really, I am very happy. I am so excited. You are my friends for many years ago till now. Every time we speak with each other, I ask you many times about digital dentistry because you are one of the best in the whole world. For me, in the whole world, one of the best, inshallah,
Thank
and
you
I'm
for that.
sure
Thank you
for
very much.
everyone. Doctor, we have some questions before we go to our lecture today. Doctor, I need from you some informations. Tell me about yourself.
Right. So my name is Mahmoud Izzat. I'm from Egypt. I graduated in 2002 from Ain Shams University in Cairo, Egypt. Got into, let's say, the programs from the Royal College of Surgeons of Edinburgh. As soon as I finished my university, I was lucky to be enrolled in a 4-year program that was at that time called Membership in General Dental Surgery, which is a specialty program, but in, let's say, general family dentistry. And I was lucky enough that at that time I was working in the Ministry of Health in Bahrain, and the people training us were lecturers or the trainers from the Royal College. They would come every 2 months and visit us and check out our cases and give us the input and lectures and the workshops that we needed to go through the program. So it was a 4-year clinical training program. And once I finished that, I went through the exam and I passed. And then I decided to go back to Egypt. I opened up my private clinic, and then I started doing my work like everyone else. One of the main objectives of going back to Cairo at that time was to start specialty training, which was the membership in restorative dentistry. And it was then in Must University in 6th of October. So I visited the university and enrolled into the specialty program as a student. And then when during the first month when I started, and this is a very funny story actually, they found that I have experience with the Royal College examination, since I'd went through the 4-year program and I was trained by the Royal College trainers. So they asked me to give a lecture about diagnosis and treatment planning. So I did. They gave me a week. I prepared myself on a PowerPoint presentation, simple, one of, let's say, my first official presentations where I stood and spoke in front of a lot of people, and these were all first, second, and third year students in the MRD program, the specialty program there. And once I started, after about half an hour of lecturing and giving the information that I had, that I was taught, I started to find a lot of faculty members starting to attend and people asking them to attend more. And then instead of it being a half-hour lecture, it became a 4-hour lecture. Everyone was asking questions. Instead of it being a lecture for 15 to 20 people, we were about 40 to 50 people, and they were all mostly faculty members. And
Oh my God.
surprisingly, at the end of the lecture, the dean met with me and asked me to become part of the faculty and the teaching staff for the membership in restorative dentistry program. This was totally by chance, and this is what got me into lecturing. Actually, I never knew that I had a passion for it, that I liked it so much, and I never knew that actually I had that's what they told me at that time, that you have a gift with speaking and you really know how to open up in front of people and give the information that you had. And this is how I started teaching. It was pure luck. And to me, it was an
Amazing.
opportunity because at the same time as I am teaching, I'm also learning. So I finished my 3-year training there, and I finished teaching there for 3 years. And then again, I kept training the membership in restorative dentistry program. Then later on in another university for another 8 years. And this is my start, or this is my beginning with teaching in universities. It was a private university at that time. And mostly I was responsible for teaching diagnosis and treatment planning. And this is where I felt that it was my passion. And this is the beginning or the starting point of any case, that if you are able to diagnose and treatment plan this case very well, then the execution you will learn by time. Even if you don't have the clinical experience, you can learn that. But what's most important for the patient, and 80% of the time that we should spend, is diagnosis and treatment planning. And since I was so passionate about that part of dentistry, I found that even more useful and effective with digital technology and with digital dentistry. Because what I found out with time is our main problem with our cases and our faults in our cases that we do and all of us do, and the things that go wrong and we repeat once more, the excuses we give our patients, the diagnosis and or the treatment plan not going perfectly as we had imagined that would happen, is we could not see the problem we had from the beginning. It was a problem with visualization. We couldn't see the whole picture at once, and we couldn't see the whole picture related to each other. We would see the defects we had in bone on its own, the defects we had with the soft tissue on its own, and the defects we had with the teeth on its own, and its relation also to the face was not there. So we'd all see all the defects in a separate, let's say, category. But to join all these parameters and all these visions in one place, to be able to diagnose and the treatment plan the case with looking at the face and then the soft tissue and then the teeth and then the bone, all of this in layers, and being able to treatment plan a case from beginning to the end. If you make it one tooth longer, then you would know the adverse effect or the effect it would have on the aesthetics, and the effect it would have on occlusion at the same time, and so on and so forth. This is what really got me interested into digital dentistry. My beginning of the journey in digital dentistry was learning about digital smile design, and this was from Christian Coachman. And then I started to lecture more about the concept. And then I got introduced more into digital dentistry because I went into the technical or to the lab part. I'm lucky enough that my technician is my partner, or she is the founder of the lab that is in my clinic, and she's also at the same time my wife. So doing everything together, and her supporting every single thing that I do. She went into a lab work from the beginning with the digital part, with CAD/CAM, of course, and 3D printing, and with the designs. So I started to understand more. I then purchased my intraoral scanner, and this was about 4 years ago. And then I started to understand more the value of digital dentistry. I started to have more experience with it, and then I went into surgical implant planning and so on and so forth. And I started to implement or try to implement digital dentistry in every single aspect in my clinic, and every single aspect of dentistry that you can imagine, because it is useful in every single part. It gives predictability and accuracy. Of course, making it faster is an advantage for the patients, but I see that it's faster not because it takes less time while you're there implementing it. No, it's faster because you spend more time planning on your own, on your computer, and less time with the patient. And this is where the true advantage is. And then about 2 years ago, I was giving a lecture in the DGOI conference in Germany. and I met Henrietta Lerner, who was the former president of Digital Dentistry Society, and we sat and talked for about 10 minutes, and within the first 2 minutes, I saw the amount of passion that she had for digital dentistry and for the society, and to spread digital knowledge worldwide in an evidence-based manner. And then I got hooked to her idea, because I had that problem of being implementing a lot of things in digital dentistry, but to be part of a society that is responsible for, as a reference to all dentists worldwide, the value of digital dentistry and the correct way of implementing it, and the evidence that we have, and doing research on tons of aspects that involve digital dentistry, and to be part of a team of digital dentists worldwide that have experience and tons of research regarding digital dentistry was a dream for me. And I was elected by Henriette as the ambassador of DDS, of Digital Dentistry Society in
Arab
Egypt.
Union.
And then we originated DDS Arab Union, which involves all the Arab countries. And I was lucky enough in the beginning of 2020 to be elected as an active board member also in Digital Dentistry Society, with our new president now, Carlo Mangano. And it's an
Congratulations.
honor actually to be part of the family. Thank you very much. And I would like to take this opportunity actually to announce something very important to me, that I would like to officially announce that Dr. Wala Al Mulla is our official ambassador for Digital Dentistry Society in Iraq. These choices are taken very meticulously, because we look for dentists that are very well experienced in a lot of aspects of digital dentistry, and at the same time or a dentist that is able to connect very well with his fellow dentists, and is considered a role model for the young dentist in his territory. And we could not find someone more appropriate for this role than Dr. Wala Al Mulla.
Thank you very much.
Thank you very much, Dr. Wala, for being a part of the family. It's a great addition to us all.
Thank you, Doctor. Really, I'm very happy and so excited about this announcement. Really, inshallah, I will do my best to do with you, inshallah, with the Digital Dentistry Arab Union. Thank you very much for this announcement. Really, I'm very happy. Doctor, I forgot the questions. Doctor, congratulations for you are the instructor of Digital Dentistry Society, Digital Smile Design 2019. You forgot that. I need to congratulate you.
Yes.
And I think you put it
elected
in your cover.
Thank you very much. Thank you.
So every time when you post something, I am writing for you. Thank you, Mr. President. My friends, my colleagues said, President of what? No, he is the president of DDS in Middle East. He is president of in Arab Union. Doctor, I have a question about your lecture. Digital dentistry now is the important for me and for you. I think for everyone, he knows many things about digital dentistry, or he knows the problems without digital dentistry, or some the accuracy with or without.
Okay.
Yeah. So people say that it's more expensive, but we said that it's more accurate. So I need your comment about that.
Well, it's a little of both, let's say. Okay, so this is a misunderstanding that a lot of dentists have, that for them, the first thing that comes into anyone's mind when you talk about digital dentistry is a milling machine or CAD/CAM technology. Okay, because this is, let's say, the first thing that everyone was introduced to that has to do with digital dentistry, even when they were in their universities. And a lot of dentists think that for them to become digital dentists, they need to purchase a milling machine and to need to learn how to use CAD/CAM technology and to buy their softwares. That's not true. Digital dentistry is much more than just a milling machine and CAD/CAM technology. Digital dentistry starts with intraoral scanners, starts with taking photos and videos. This is the beginning, and this is the beginning that I tell everyone to start with. Buy a DSLR camera, start taking photos and videos. You have become a digital dentist because you are documenting in digital format. Your next step into digital dentistry, if you want to invest, is to buy an intraoral scanner, right? A person who wants to buy a CBCT, that's great. If you have the money, you don't have to, because we have a lot of, let's say, imaging centers that can provide that service for your patients. The next part of digital dentistry is the processing, is where we take all this information from the intraoral scanners, cameras, videos, and the CBCTs, and we start to register them to each other and implement them and start to do our planning on these softwares. And this is the part where we start to process, and then after that we can start to manufacture on milling machines and 3D printers. The misunderstanding that a lot of dentists,
little by little.
Yes, step by step. That's number one. Number two, also, it's not step by step in purchasing, meaning it's a step by step in understanding and in implementing and using. If you do not want to invest any type of any money at all in digital dentistry, that's very easy. All you need to do is to invest in the education, meaning that just buy a camera. This is something that has to be in every single clinic right now. There's not a clinic in the world that can go on without having a DSLR camera. But you do not need to buy an intraoral scanner. You can take an impression of your patient, send this to your lab technician. He will pour it into a model and he will scan it for you. And then you have that in STL format or in digital format, right? You can send your patient to a imaging center and they can do the CBCT for you. You can outsource your planning with an imaging center or with a lab that does designs for you, and you can very easily, like we are doing a conference or an online meeting right now, me and you and hundreds of people, you can just go online with your lab or you're with their imaging center. You can go, you can share screens and they can show you the whole plan, and you can be part of this plan to make sure that this is what you want, and they can do the planning for you. And then they can also, after you finish the plan, they can manufacture for you, they can mill for you, and they can 3D print for you. All you need to do is to learn as a dentist how to use these guides that they have fabricated for you. And by time, you will start to understand where your biggest interest in digital dentistry is and where you would like to invest your money at a later step if you want, and then invest. But to me, what I believe is the best investment, or the starting point of investment into digital dentistry, camera, of course, that's number one. Intraoral scanners is the second choice, but that doesn't mean that you have to do the investment first to implement digital dentistry. You can so simply implement digital dentistry without doing that huge investment if you do not have the finances for that.
Great. Doctor, I'm waiting till now. I'm waiting your amazing lecture. Every time you have wow effect. You remember? You have wow effect. You have emotional. So really, I need to have both of them. I need to see your amazing lecture. Doctor, after 2 seconds, I will present your lecture.
Okay,
wait for me. Now, Doctor, webinar is yours.
Okay, so you want me to play from the presentation, correct?
Yeah.
Okay, perfect.
Yeah.
Right. So, can you see full screen, Dr. Wallet? I think the presentation, it's a bit lagged. Yes. Oh, there. Okay, perfect. Right. So, Dr. Wallet, can you hear me? Hello?
Doctor?
Hello?
Yeah.
Can you hear me?
Yes.
Perfect. Okay, should I start?
Okay.
Okay, excellent. I can't see you in the screen there. There you are. Okay.
Yeah.
Right. So, what we're going to talk about today, there was a lot of wow effects and emotional dentistry that we already spoke about my past live lecture that was on last Thursday. And I asked everyone to attend the first lecture because the remaining lectures will depend on them. But if you haven't attended the first lecture and you have any questions, of course, please feel free to ask. So we'll be talking about digital treatment planning of gummy smile cases and how we can use digital technology to make this an easier process and to have better visualization and to be able to treatment plan our cases in a better fashion. Now we have one main problem with gummy smile cases. Actually, this is something that's very common in the Arab world. Most females have gummy smiles and they don't like it, okay? And this is something more ethnic because it's more common and they want to get rid of their gummy smiles. But we have one main problem with us as dentists, and this was one of my also problems, was that as soon as I saw a gummy smile case, the first thing that came in mind was this patient needs crown lengthening, and that's not true. And what I saw later on was also that people are choosing, or dentists are choosing treatment options depending on which procedure they're more familiar with and which procedure they like to do more, which involved lip repositioning, let's say, or Botox or fillers or whatever, not depending on why or the main reason that this patient has a gummy smile. And then the treatment plan is according to the reason. And something also that we have to put in mind, that gummy smile cases are multifactorial. It's usually not just due to one reason. There are several reasons usually to a gummy smile. So this is what we're going to discuss with each other today, a simplified process of evaluating the gummy smile case, knowing the reason behind the gummy smile, and accordingly the treatment plan, so the diagnosis and the treatment planning. And we're going to do this in a simplified process of just taking 2 photos for our patients, and using these photos we'll be able to diagnose this very simply. So this was part of our lecture on last Thursday, showing the different applications that we can use digital dentistry in, of course, all applications of digital dentistry, and also what we can use digital smile design for. And of course, the crown lengthening and restorative part is what we're going to talk about today. We talked about the additive and subtractive restorative cases in the lecture on Thursday. Tomorrow I have a lecture that will involve the implant restorative part and the fully edentulous part. And then on Wednesday, I will be talking about the vertical dimension or VDO restorative part, which involves occlusion. And then also next Saturday night, I'll be talking about this concept that I have fabricated that I call digital direct composites. So we'll be talking about all aspects of digital dentistry, or all aspects of dentistry that you can use the digital technology in, right? So today we'll be talking about the gummy smile cases. Now have a quick look at this case. This patient, of course, you can see from the photo, has a gummy smile. And I would like you to have a look at the video also, because this is very important. Because as we said before in the lecture, that you cannot only depend on the photo, we depend on the photo for the design, but patients that usually have gummy smiles are very aware of that gummy smile that they have. They are aware of the effect and they try to hide it as much as possible. So the video shows us dynamics and the photo is what we plan on, and the video always has to be a reference. And of course, as we said before, we start with a facial analysis for our patient, and then we go down to the teeth. So we start with the extraoral evaluation, and then we go intraoral. So to be able to diagnose any gummy smile case, we can very easily just ask ourselves 5 simple questions. Okay, so this is the important part, and this is the part that I will mostly stress on, so that because when we have a workflow or a way, an easy way to, and an easy and predictable way to diagnose a case and then get to the treatment plan, it's usually used. When it's something difficult and not so easy to use, then we usually just find other ways, or we don't do it to the best extent that we can. Okay, so the first question that we always ask ourselves is facial height. Is the upper and the lower facial height equal or not? Or sorry, is the middle and the lower facial height equal or not? Our faces are divided into 3/3: the upper facial height, the middle facial height, and the lower facial height. So the lower facial height is from the base of the nose to the chin. The middle facial height is from the base of the nose to the glabella, and the upper facial height is from the glabella to the hairline. What matters to us is the middle and the lower facial height. So the first question we're going to ask is the middle and the lower facial height equal? Is it 1-to-1 or not? The second question we're going to ask, and you're going to understand more, of course, in the coming slides, what this means or what this will implement to regarding the gummy smile. The second question is divided into two parts. What is the patient's lip length? Meaning that our average lip length from the base of, or from the vermilion border to the base of the nose is usually 20 to 24 millimeters. Okay, so our average lip length is usually 20 to 24 millimeters from the base of the nose to the end of the upper lip. So what about lip mobility? Lip mobility is usually 6 to 8 millimeters, meaning that when someone is from rest position to a full smile, then the amount of mobility of the upper lip, or the distance that the upper lip has moved, should be an average of 6 to 8 millimeters. So the first question is facial height, is it equal or not? Second question is divided in two parts. Is our lip length 20 to 24 millimeters or not? Is it normal or not? Is our lip mobility normal or not? And the normal is 6 to 8 millimeters, and the normal lip length is 20 to 24 millimeters. The third question is the gingival line. Is the gingival line straight or not? What does that mean? Meaning that the zenith points, let's say, of from the canine to the canine, is it in a straight line or not? That is the third question, and we'll know that what that implies to in the coming slides. The fourth question is the tooth length 10 to 11 millimeters or not? Because this is our average tooth length. So is the tooth shorter than 10 to 11 millimeters or not? And the last question is, can you feel the CEJ, the cemento enamel junction, within the sulcus or not? And this is a yes or no question. So just using those 5 questions, I'm going to show in the coming slides how I'm going to very easily diagnose my case and reach a full treatment plan, or have treatment options for the case, and accordingly go to my definitive treatment plan. As we said, one of the most important aspects of any case that you're treating is diagnosis and treatment plan. So going back to the first question, facial height, as I said, we start with 2 main photos to be able to answer all these questions. Instead of answering these questions with the patient in front of me and measuring lip length and measuring lip mobility, which is quite difficult, asking the patient to smile real hard and then wait, this is where the lip was, we started from rest position, this is how much we moved, and measuring facial height and measuring also the gingival line, just so simply take photos and do the measurements on the photos. And this is the way I thought to make it much easier for me, because when you usually have these, even with these 5 simplified questions, usually I would drop something out and forget some one of the questions, and then when the patient was with me, and then I would need to bring my patient back in so that I can answer that question that I forgot, so that I can get my correct diagnosis. But when I have photos there, it's as if the patient is already there, given that I've taken the positions that will help me to answer these 5 questions. So I started thinking out of the box a little, and started to think of a way, or which photos do I actually need to be able to answer these 5 questions. These 5 core questions were introduced by Bill Robbins, and I will show you his book. That is a fantastic book that you should all read and use as a reference for Gummy Smile Cases. I only thought of a different way of making this easier to do the diagnosis. I'm the one who thought of taking the photos to be able to use this for your diagnosis, and started to think out of the box of which photos I can use for that. And I will show you the textbook at the end of the lecture as a reference. Okay, so what I started with was taking a rest photo and a full smile photo, but you have to make sure that this full smile photo is actually what the patient is at the maximum smile. So after you take the video, you have to make sure the position of the upper lip while the patient is smiling at full, and then try as much as possible to have the patient smile that hard when he is looking straight at you. Now, the photo, the head position is very important, because this will differ in your diagnosis. As we said before in the lecture before on last Thursday, that the patient has to look straight in front of you. Both ears have to be equal on both sides. You have to have a full smile. The patient cannot look down or upwards, and cannot look to the side, right or left. How do we know if they look to the side, right or left? or not. We can see that both ears are equal on both sides. Of course, if the patient looks down, you can see that, or looks higher up, you can see that very closely. The eyes have to be open because we need the eyes there later on to do the smile design for the patient, and we need the full smile. With that photo, at the same time, we also need a rest photo, and this rest photo has to be at this exact same position as the smile. So how do I start this out? I ask my patient to stay at rest first. I adjust his head position, make sure everything is okay. And once the patient is at rest, of course, my camera is on the tripod. I'm in one position. I tell my patient, I'm going to take this photo right now. Do not move your head. And after I take the photo, give me a full smile pose without moving your head at all, because I want to compare both photos to each other so that I can take the measurements, or I can answer the 5 questions that we were talking about. Okay, so patient starts with rest, both ears equal, eyes open. He doesn't look down or up, looking straight forward at me. I have my tripod, my camera on the tripod. I take the first photo, tell the patient not to move at all, give me a full smile, and then take the second photo after it at the same time. Of course, both at the same magnification, because I haven't moved and the patient hasn't moved, and this is where we use these 2 photos. So what I'm going to use first, I'm going to use only the rest photo first. I'm not going to use the smile now. We'll use the smile later on in the coming questions. So using this rest photo, so simply bring in 2 or 3 horizontal lines. Bring 1 horizontal line at the glabella, the second horizontal line at the base of the nose, and the third at the base of the chin. And so simply you can calibrate your ruler on any PowerPoint or Keynote software if you want, and you can measure the distance, or even if you do not calibrate, it's not a problem at this point, but later on you will need to calibrate your ruler. I know I will be asked this question: how do we calibrate our rulers? Those that have we have taught or know how to do digital smile design on Keynote or PowerPoint will be able to do this very easily, or already know how to do this. Those who don't, it's a quite simple process. We have this virtual digital ruler on our Keynote or PowerPoint templates that we have from our DSD templates. And we bring in this ruler and we measure with this ruler the distance between the 2 centers. Or what we do first is we measure intraorally in the patient's mouth, okay, the distance between both centers. So let's say that I brought in my caliper to my patient's mouth and I measured from the distal of one central to the distal of the second, that the distance between both centrals was 16 millimeters, okay? So according to that measurement, I'm going to just exit the presentation for 1 second, because I want to show you this as a hands-on very quickly so that you can understand, right? So I measured 16 millimeters in the patient's mouth. I'm going to bring in a line that shows where the distal of the central is here and the distal of the second central is here. So that's just easier for me to measure. And then I'm going to bring in this virtual ruler, okay? And then I measured 16 millimeters in my patient's mouth. So simply, I'm going to decrease the size of my ruler till I get to the 16 millimeter mark right there, okay, on the software, okay? There, just a second. I'm going to go till I get to 16, there. So now it's reading 16 exactly. So what have I done now? I have distorted this ruler and calibrated it to the same measurement that was in the patient's mouth. So any measurement that I do with this ruler now is the same measurement on the photo, and it's the same measurement in the patient's mouth. It's that easy. So again, measure the distance between any 2 points you want. Usually both centrals is the easiest way. Measure the distance between 2 centrals. Bring in 2 lines if you want, so that make it easier. Bring in this ruler, distort it till it reads the 16 millimeters that you measured in the patient's mouth, and everything is calibrated, and you can measure any measurements that you do on the photo are exactly the same as the measurements that you have in the patient's mouth, okay? So from there, we then measure that the patient's middle facial height is 61.5 millimeters, and the patient's lower facial height is 72.5 millimeters. So that means that we have overgrowth of the patient's lower facial height. And this overgrowth will reflect on why the patient has a gummy smile, because the overgrowth is not in the whole lower facial height, it's in the maxilla. So this is what we call vertical maxillary excess. The maxilla has overgrown in vertical dimension. Therefore, instead of the teeth being in this position, the teeth are in a lower position. And when the patient smiles, the patient shows more gums and teeth than normal. It's that simple. So accordingly, so this is our first diagnosis. So now our first question was, is the facial height equal? The middle and lower facial height, is it equal or not? We found that it is not equal. We have increase in the lower facial height. So we have vertical maxillary excess. This is our diagnosis. And accordingly, we have two treatment options for this type of case, either to go for an orthognathic surgery or to mask this vertical maxillary excess with Botox to the lips to decrease the function or the movement of the upper lip. And this is one advantage that we have now from Botox. Okay, so this is the first question that we answered. Is that all? No, we go on with the rest of the 5 questions because, as we said, gummy smile cases are usually multifactorial. Okay, so the second part or the second question is lip length and lip mobility. And as I said, again, we are still going to use only the rest photo, right? So we're going to measure lip length now. So very easily, just bring in 2 horizontal lines. We measure the lip length from the base of the upper lip to the base of the nose. And the average is usually 20 to 24 millimeters, depending if male or female. And this patient has 22 millimeters. So he has a normal lip length. So what if he had a measurement less than 20 millimeters? Then we would diagnose him as having a short lip. And because the patient has a shorter lip, then he shows more of his gums, right? And then our treatment option would be lip repositioning. So we only choose lip repositioning when this patient has a short lip. And we only go for an orthognathic surgery when the patient has increased or vertical maxillary excess. So every treatment option we use is done for a reason. We just need to detect if this is the problem that the patient has or not. So the second part of the second question is lip mobility. And this is where we need to use both photos. And this is why both photos have to be taken at the same magnification and same head position. Because when I put both photos near each other, I want to measure lip mobility. I want to measure lip mobility from rest position to full smile position, correct? So now I have both photos. I can so easily compare both photos to each other. Bring in a horizontal line at the base of the lip while the patient was at rest, and bring in another horizontal line. Dr. Wala, I think that they can't see the left of the patient's face on the screen.
Yes, the smile.
Or yeah, or I think that the presentation is stuck actually. Okay, I can only see you now. Maybe I needed to refresh because on my phone I could see that you could. Okay, can you play the presentation once more, Dr. Wala? Can you hear me?
Yeah, I am hearing you. I hear you, Doctor. You mean?
Just a second. I think that they can't see the left of the patient's face on the. Okay, right. So.
Just it needs minimizing only.
Or, I need to minimize.
Yeah. And close. Yeah. Close the application and reopen it. Resize it. Okay, that's it. Okay. Both of these photos are available now. They are shown.
Yeah, but are you sure? Because because I think you are. What I can see that I'm stuck on the presentation. I don't know. Maybe my internet is slow, but you can see that what everyone can see, right?
Yeah.
Dr. Wala?
Yeah.
Okay, so it's good.
Okay, full screen. They need full screen.
Yeah, they're going to need full screen. So let me go to full screen and see what happens. Yeah. Can you just ask on the with a message? Can you all see us?
Our colleague, our colleague asked, make it full screen. guys, Dr. Izzat, he is working on the presentation. He is working on the PowerPoint or Keynote to show you the calibration, how to calibrate the ruler inside, like when it's transferred from a patient to the photo. Because of that, it's not a full, because they ask me make it a full presentation like play.
Yes, can you all see my screen now?
Yes.
Let's just wait
Yeah,
so
they
that
said,
everyone can answer.
Dr.
Yes?
Abdullah said, yes, it's good now.
Okay, so excellent. So going back to lip mobility, right? So to be able to measure lip mobility, I need both photos, right, to compare them to each other. Because to be able to measure lip mobility, I need to take the patient from rest position. I need to measure where the upper lip is, or the base of the upper lip is at rest. And then when the patient is at full smile, I need to know where the base of the upper lip has gone, right? The distance that I have moved, or the patient has moved his upper lip while smiling. So simply, this is where I use both photos. I bring in the horizontal line at the rest position at the base of the upper lip, and another horizontal line at the base of the upper lip while the patient is at full smile. And because my ruler is calibrated once more, and I'm using both photos that have calibrated my ruler on, I can measure the difference between both lines. And here we found that the lip mobility that the patient has is 11 millimeters. That means that I have an excess of mobility of about 3 millimeters. So now I know that he has a hypermobile lip, meaning that his upper lip is moving at a larger extent than normal. And this is where the best treatment option for this problem would be Botox, because Botox decreases the muscular activity of the upper lip, right? And later on, we will see also that we are able to, at an average, not only know that we need to give Botox, but because we're starting to get, we now have two major reasons why this patient has a gummy smile, right? The first is the lip mobility. Sorry, the first was the vertical maxillary excess, and the second was lip mobility. So if we are a multifactorial case, we'll be or we will be able to measure how much of Botox I need to give and how much of, let's say, crown lengthening I need to do, so that I can diagnose my case, or I can treat my case in the perfect or the most suitable way for the patient. So that was my first two questions, correct? The first question was, let me go back so that you can all be with me. My first question was facial height. The patient had vertical maxillary excess. The treatment option was orthodontic and Botox. The two questions we had later on were lip length. He had a normal lip. If he had a short lip, we would need lip repositioning. And then we found that the patient has lip mobility because he has a mobility of 11 millimeters. And this is where we use both photos. And we found that the patient needs Botox for the upper lip to decrease the lip mobility. So question number 3 is the gingival line. I bring in a horizontal line to that same photo that I took of the patient with the full smile. I just cut out or cropped the rest of the face because I only want to look intraoral now. If you want to take, of course, another photo, this is okay, but I recommend that you use this same photo. Why? Because when I bought in this photo, and this is a very important point that I forgot to show you, that when I bought in this photo, there's sometimes when you take the photo that the patient's head is rotated just a little, right? You can see that the patient's head is totally straight. How did I adjust the horizontal of my patient's face? Using the first step that we do while doing the smile design process. We bring in a horizontal line, we adjust it to the interpupillary line, we adjust it to the intercommissural line, and we rotate the photo till we have adjusted our horizontal. Only then do we use the photos, and we do the same also for the rest photo. So when I bring in this photo cropped from my facial photo, it is at the correct horizontal. So when I bring in a horizontal line and place it at the gingival margins of all the teeth, from the canine to the canine, we can see that we have at average no problems with our gingival margins, that they're normally at a straight line. So what if they weren't at a straight line? We would have something called dentoalveolar extrusion. What is dentoalveolar extrusion? Usually our teeth stay in eruption, or what we call active eruption happens during growth, that your teeth keep erupting in an occlusal direction till they are in function, until they touch the opposing, right? So what if we have a class 2 patient? usually what happens is the centrals and the laterals will keep over erupting, and they will not find anything as an antagonist. And therefore, when the centrals and laterals have over erupted, what moves with the teeth when they move in an occlusal direction? The periodontium also moves with them. So accordingly, we would have the incisal edge of the centrals and the laterals at a lower level than the rest of the rest of the teeth, which is the canines and the premolars. And also we would have an anterior gummy smile because the teeth would move downwards, and the gingival complex, the whole periodontal complex will move with them. So we would have an excess of exposure of the gingival tissues. If you cannot, let me go show you that very quickly a photo of a case with a dental alveolar extrusion so that you can imagine more. If you look at this case, if you look at the gingival margins of the centrals and the laterals, they're at a lower level than the canines. And you can see that we have an anterior gummy smile. Why? Because this patient is a class 2 patient, and the teeth kept in the process of over erupting, and during the eruption phase, the gingival complex moved with the teeth also. So we have an anterior gummy smile. Okay, so what do we call this process? We call it dentoalveolar extrusion. So going back to that same case that we were showing, that from where we were understanding the whole process. So the third question is the gingival line straight or not? So are the gingival margins of the canines, laterals, and centrals nearly at an average at the same level or not? Or are the gingival margins of the centrals and laterals, for instance, like the last case that I just showed you, at a lower level? So if they are at a lower level, and also my incisal edges of the centrals and laterals are at a different level than the canines and premolars, now I'm sure that I have something called dentoalveolar extrusion. And this is my diagnosis. And the treatment options for dentoalveolar extrusions are one of two: either functional crown lengthening or orthodontic intrusion of the anteriors. And usually in these types of cases, we go for intrusion if possible with the patient, and the second choice is the functional crown lengthening. So this was
Doctor,
question. Yes.
yeah, Doctor, is that one of our colleague
Mm-hmm.
asked, or he mentioned something. So the treatment of choice is Botox combined with orthognathic surgery for this
Yes, till
case.
now, but I haven't finished the rest of the questions yet. For every case, I have to ask myself those 5 questions, all the 5, because as we said, the any Gummy Smile case is multifactorial, and you will see this in this coming slide, that it's not only because that the patient has a hypermobile lip and that the patient has vertical maxillary excess. No,
Yeah.
the patient also will need crown lengthening, but we have to complete the questions so that we can reach the correct diagnosis.
Yes.
Okay, so
Yeah.
question number 4 is tooth length. And again, I will use the smile photo that we used in the past slide, which was the facial photo of the patient while smiling, but I just cropped it. And again, I have also still calibrated this photo very easily. Just don't make it bigger or smaller so that your ruler stays calibrated. Okay. And when we measured the clinical crown height of the patient, which is what you see with your eyes, it is 7 millimeters. So our average tooth length of the central is usually 10 to 11 millimeters. So it being shorter could be a question of wear or variation in anatomy. This is possible. Or it could be hyperplasia of the gingival tissues for now. Okay. So we already had a CBCT for our patient, and we could measure on the CBCT, because the CBCT is 1-to-1. We found that the true height of the central was 10 millimeters. You can see the reading here is 9.92 millimeters of the central. So what does this mean? This means that the gingival part of the tooth is covered by soft tissue or bone or both. We don't know yet. Okay, but we know that the rest of the tooth or the neck of the tooth is covered by soft tissue or bone or both. Okay, so we know that there's a part of the tooth that we need to expose gingivally, but is it going to be a soft tissue crown lengthening or a hard tissue crown lengthening? This is the question, and this is where we ask ourselves the last question. Now, if you don't have a CBCT here to measure, this is a quite easy procedure. What you can do is bring in your periodontal probe into the sulcus and start to look or feel for the CEJ. Bring your periodontal probe parallel to the tooth. Sometimes you might need to give anesthesia for the patient for this if the CEJ is beneath the sulcus depth of your patient, and just pull your periodontal probe to the outside till you feel the step of the CEJ. But sometimes this is not easy to do because some patients do not have prominent CEJs, so you will not be able to really actually accurately feel where the CEJ is. And this is where CBCTs, to me, are very, very important with diagnosing gummy smile cases. Any gummy smile case I have, I take a CBCT for, and we'll see this in the upcoming slides and its importance, but this is the first part of its importance, to be able to detect very accurately where the CEJ is. So going back, the fourth question is tooth length. Is it 10 to 11 millimeters or not? We found that we have a short tooth. So till now, we know that we need some type of gingivectomy, or let's say soft tissue crown lengthening, but we don't know if we need to do bony crown lengthening or not. And this is where the last question comes in. Can you feel the CEJ within the sulcus or not? And this is so simple with the periodontal probe. Bring it in till the end of the sulcus and start pulling it out parallel and see if you can feel a step or not. If you cannot feel the CEJ within the sulcus, that means that the CEJ is where? Is beneath the sulcus. That means that it's covered by your biological width or covered by bone. And this way or that way, that means that you will need to do an osseous crown lengthening. What do we call this process? We call it altered passive eruption. What is passive eruption? Passive eruption is a normal process that happens to all of us with active eruption at the same time. What usually happens during growth is the tooth keeps erupting, and then the gingival tissues will start to creep till it reaches 1 millimeter or 1.5 millimeter from the CEJ or at the level of the CEJ, which is, if as a simple example so that you can all understand and relate, why did they all tell us in fixed prosthodontics never to do a crown for a patient unless he has passed 16 to 18 years of age? Because they used to make us understand that the gingival level will be or your gingival margin will be at a different level later on if the patient has not finished growth. That is passive eruption. Passive eruption meaning that your gingival level is at your gingiva is usually covering your a very big part of the CEJ during growth, and then after the active eruption and passive eruption, which is the movement of the gingival tissue to the level of, or the gingival tissue creeping to the level of the CEJ or just above it by 1 millimeter, this is what we call passive eruption. So when this does not happen, meaning when the gingiva does not creep from the tooth and reach the CEJ, this is what we call altered passive eruption. So what this patient has here is altered passive eruption, and this is when we decide that this patient needs aesthetic crown lengthening for him. So if we go back to those 5 questions, and this was we concluded this again when we overlapped the photo to the CBCT. This was a very easy process, and we could see that the measurement of 7 millimeters were here where the gingival margin is, and we could see that the rest of the tooth was covered by bone. And if we look at another view to the CBCT, we can confirm this also. So if we go back to those 5 questions again, so that we can revise all the questions that we asked and the process that we used. The number 1 question was facial height. We found that the lower facial height was much longer than the middle facial height, so the patient has vertical maxillary excess. So our treatment option here will be either orthognathic surgery or Botox. We do not stop there. We always ask the 5 questions. The second question, 2 parts, lip length. We found that his lip length was normal. Lip mobility, we found that the patient had a hypermobile lip, therefore he will need Botox. The gingival line was straight, so the patient will not need intrusion of the teeth or functional crown lengthening. Tooth length was 7 millimeters, much shorter than the average. So we decided in the beginning that for sure that a big part of the tooth is covered by soft tissue. So we decided that he will need soft tissue crown lengthening till now, until we ask the last question, which is, can you feel the CEJ within the sulcus? And if you cannot feel the CEJ within the sulcus, that means that we have what we call altered passive eruption, meaning that the patient will also need osseous crown lengthening with the soft tissue crown lengthening. So our treatment options for this patient are orthognathic, Botox, and osseous and soft tissue, of course, crown lengthening. And this is where we put the patient in the phase of choosing the treatment options at the beginning. Knowing this information, we then started doing our smile design process, where we started, of course, with the 8 steps that I explained last Thursday, starting with the horizontal and then our midline, and then adjusting the smile curve, and then the 80%, bringing in the 80% box and the interdental ruler first, where we have the red proportion, where the width of the center is proportionate to the lateral and canine. And then we bring in the 80% box according to the new width of the centrals, because he has a diastema between the centrals. And this is where we integrate the smile design and the face to the diagnostic information that we have from the 5 questions that we asked. And when I bought in the 80% box, we found that we will need so that we give the patient the ideal ratio of height to width ratio. We found that we will need to make the central longer about 2 millimeters. And when we went back to the CBCT, we found that those 2 millimeters that we need, if you remember, that our height, the crown height was 7, and the actual height of the central till the CEJ was about 9.92. So this confirms this also, right? So we know that we will be at just below or at our cemento enamel junction, meaning that we will not need to, if the patient wants to go, let's say, for prosthetics later on after the crown lengthening, if we go on the root surface, then we will not need to fabricate a crown, which is unethical and not biological at all. So we always need to stop at the CEJ. So if this patient in the future or at the same time after the process of crown lengthening wants to go for a veneer, we know that we are on pure enamel and we are at the CEJ or below the CEJ level of 1 millimeter. And also where this is augmented is, if you can see, that we also decided that we needed to make the teeth just a little longer incisal. Okay, so according to the new incisal edge position of this patient, we then gave the 80% box to this tooth, and we found that the new level of the gingival tissue will be in this area. And you can see also the relation of the upper lip to the new gingival margin. The patient had a gummy smile of about, this is about, let's say, 7 or 7.5 millimeters. And we're only going to remove about 2 millimeters of this gummy smile for the patient. That means that the crown lengthening procedure to reach the CEJ, our limit is 2 to 2.5 millimeters. So what about the rest? The rest you can get with the Botox and the orthognathic surgery that we decided on doing for the patient. Or if the patient doesn't want to go for orthognathic, you can do Botox instead. So now we're not only knowing where our defect is and treatment planning accordingly, we are also adjusting the gummy smile if we want to get it to the 0 level or to an exposure of 1 to 2 millimeters, right? We know how much of crown lengthening we need to do according to the small design process that we have done, according to our new smile curve and the width of the tooth, and according to the upper lip, where or the amount of Botox that we need to give the patient, so that we don't give them a larger dose and we cripple or paralyze the lip to a large extent, and so that we get that beautiful smile back to the patient that he was always asking or dreaming for. Okay, so according to that plan, we completed our full smile design process. This is the process that we finished, and this is the photo that we sent our lab technician. And from there, we did our mock-up for the patient. This was a patient that we did. He's a dental student in university, and this was live in front of 150 people. Him seeing the mock-up and his reaction to it. He liked what he got. Of course, this is the emotional dentistry concept and the motivational part that we talked about, and the importance of the patient knowing or seeing the result beforehand to meet his expectations. This is something that is very, very important, and we all have to do, because we're going to do a lot of procedures for this patient, and he has to actually, it is his right to know what he's going to get before we even start. and he will never imagine what he's going to get unless you show this with motion. I love showing 2 videos of a before and after, so the patient can really understand what he's going to get, and he can see the full extent from his smile. From this mock-up that we showed the patient, we wanted,
Doctor,
of
please,
course, our
the
treatment.
photo,
Yes.
the photo of the patient. I think the mock-up it's not shown here now. Check your presentation because I
My
think we are.
presentation is a little late, Dr. Wala. It's not at
Ah,
the same speed that I'm speaking.
yeah.
Everyone in the group, did you see the video of the patient before and after? Please
Yeah.
give us an answer so that we can complete. Are you getting answers, Dr. Wala?
No, till now we can't see things doctor are talking about the mock-up and this kind of stuff. Yes.
So they
Doctor,
didn't see the video.
yeah, they didn't see.
Okay, I'm going to go back a slide. Can just see that that you have a slide with 3 photos of the patient in the slide.
No, till now
You have the slide now.
we are sticked on tooth length. The
Oh
crown of
my!
yeah. 1, 2, 3.
So there's a very big lag.
Yeah.
I don't know. Is that my internet or
No,
where
doctor.
usually is the problem?
Broadcast, it's differ from when you see on your Facebook or YouTube. But here for me it's real time. I watching you as a real time.
Okay, so I think it will be transmitted, video not shown.
Here?
Okay.
No. It's transmitted okay. But till now the photo of tooth length shown in the presentation.
Okay. I'm at a totally different slide now.
Mhm.
Let's wait for it to catch up.
Yes. As I said, I see only CBCT slide.
Okay.
Yes.
Yes, that's what I can see also on
They
my
need to
phone.
see, doctor, they need to see video. And we will not
Yeah,
close this live without video, please.
of course, of course. But it's just that it seems that the internet is a bit slow,
Yeah.
and that's why it's transmitting at a different speed than than the speed I'm talking at. I can even see on my phone what's happening now is it's playing about a minute before. You know what I mean?
Hmm. So for broadcasting, it's 1 hour, 2 minutes.
Okay, on the broadcast, it's 1 hour, 1 minute, 53, 56.
Yeah. But the photo is sticked on the CBCT and tooth height.
Okay. So it's just that it seems that the internet is a bit slow.
Yeah. Yes. Now
Okay.
it's okay now. But where's the video, doctor?
I'll come to the video. Don't worry.
Yeah. Okay.
Okay, I'm going to play full screen now. Okay, and tell me if you can still see.
For broadcasting, it's one.
Okay, on the broadcast. Well, can you see now?
Yeah, guys, it's
You
okay
can see.
now. Yes. Yes.
Can you all confirm? Everyone confirmed? Okay.
Yeah, it's 3 photos.
Yes. Okay. So the coming slide. This is the video. Can you all see the video now?
No.
So the speed that I'm speaking at is totally different than the speed of the presentation, I guess.
Yeah. We are waiting.
Can
Doctor, it's on
is the
slide.
video there?
No. Doctor, go down. 1, 2, 3. 3 times.
Can you see the video now?
No.
So someone says yes, confirm. We can see the video. Okay, so yes. Okay, so going back to the video and its importance, showing this to the patient from the beginning. Well, are we
Doctor,
okay?
there is no video. No, there is no video.
No video.
Yeah, doctor,
Okay,
play the presentation. Play it. Play the
it is on
presentation.
play.
No, no, it's not on play.
Now it's play.
Doctor, go up once. Go up
There.
because now you are in the slide after the video.
This is the
I
video.
I am watching. Yes, I'm watching the
Now the video
slide
is playing.
for your computer, but
For
for
some
us, no.
reason, the video doesn't want to play. I don't know why. It's showing all the slides except for the video.
Mm. Doctor, you can send the videos for me. I will publish it in Dentilinium.
Okay. Well, I think we should go on and try at the end to show everyone the video.
Yeah.
Uh,
So you can share your screen, doctor.
I don't think
You
it's
can.
that important now. Well, can you hear me?
Yeah,
Well,
yeah. I'm hearing you.
can you hear me?
Yes.
Should we go on?
Go on.
Okay. So uh, the video is just a video of the mock-up for the patient. I can post this later on if you guys want. No problem at all. You haven't missed a lot. So continuing with the case.
Yes.
So we have now reached a full treatment plan for the case. We know exactly what we need to do. The patient, because he saw the video and he liked the result very much, actually, he only wanted to go for crown lengthening and then veneers because he had multiple spacing between the teeth. And he said that I will try that first because I saw the result with the mock-up and I like it because we cannot stimulate, of course, the Botox during the mock-up stage. And I will see later on. I want to decide later on if I'm going to do the Botox or not. So we totally agreed with him, and this is usually the approach that we take. That because the Botox is not a permanent solution. It fades within 4 to 6 months, and you have to redo it once more. He's a dentist, of course, and he understood that. So he wanted the permanent solution first. We usually start with the permanent, and then we go with the temporary, which is Botox with the Botox. So from there, from the wax up we did a digital wax up for the patient, and on the digital wax up, we fabricated a guide. And this is the old way we used to fabricate our guides on the printed model of the wax up. We would do on it a vacuum form stent of night guard material, hard, and we would adjust it so that we would have space for the gingivectomy, as you can see here, according to our wax up, and a place or something, or the guide shows us where to remove the bone exactly after we raise a flap so that we can remove bone around the tooth. Okay, well, can you hear me?
Yes.
Okay, perfect. So according to our diagnosis, according to our smile design, we then reached where our new gum levels are. We chose our teeth library that we're going to use. We did this as a wax up, and on the model that we have as a wax up, we fabricate then this vacuum form stent, which gives us not only information about where the new gingival level is, it shows us also the shape of the zenith of the new shapes of teeth, because the patient is going to go for veneers. So we chose a certain library with certain zenith. As we said before, we use natural tooth shapes, and according to these natural tooth shapes, every tooth has its own specific zenith point. Accordingly, we did our gingivectomies according to the shapes, and we also have our new bone levels, which is information that we took from the CBCT, and also according to the patient's phenotype or biotype. If it's thin or thick, we decide if we're going to use, if we're going to leave 2 or 3 millimeters of biological width for the tooth. And then this is here during the surgical procedure of doing the gingivectomy using the guide. And then the bone was removed for the process itself. And then later on, after healing, of course, we started to fabricate for our patients at these new gingival levels our veneers. Something very important that I like doing is I
Doctor,
temporize
change
my
the
patient.
photo.
Excuse me?
The slide. Stick on now on the surgical procedure.
Okay. Uh, okay, just give me a second. Let me just make sure of the Wi-Fi connection. If there's something
Okay.
wrong with it with me, just give me one
o-
second, please.
Okay. Okay.
Okay, I'm back. Wala, can you hear
Welcome back.
me?
Yes.
Wala,
Yeah. Yeah. Welcome back. It's okay.
wala.
Yeah. Do you hear me?
Hello.
Hello.
Wala.
Do you
Yeah,
hear
yeah,
me?
I can
Yes.
hear you.
Okay.
Yes.
Yeah.
Okay. So can you
Yes.
see my slide again, or
Yeah. 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 Okay.
you can see the slide now?
Yes.
Okay, perfect. So, one of the things that I prefer always doing after a gingivectomy or a crown lengthening or any gingival procedure that I do involving my patient is I like to temporize my patient, because when you temporize the patient, this is where you are able to guide the soft tissue to heal around your restorations and give you the correct shape and health that you want around the restorations itself. We will show this in a coming case. These are the final veneers of the patient that we got, or the final veneers the final results that we gave our patient after the crown lengthening procedure. I like to always emphasize on this photo. You can see the gingival health that we have around the veneer margin. And a lot of people ask when we bring in our final design, meaning that when we do the mock-up is usually additive. And when we do our final design, this is the ideal position of the tooth. So how do you know how much you should bring in the teeth? Of course, other than the patient's facial profile, one very important point is we bring back teeth to the way that God has made them, meaning that the gingival tissue is, of course, is more prominent than the tooth margin and the tooth structures. We bring it in till we are at the correct position according to the gingiva, so that we have good gingival health around our restorations. Well, are we okay? Are we at the same slide now?
Yeah. You are on
Okay.
the yes on the results.
Okay, and you can
Yes.
see the slide of the side view
Yes. Yes.
of the case.
Yes. Yeah.
Excellent. Okay, and you can see the smile photo of the patient before and after. The patient was happy with the results. He did not want to go for Botox later on, and he was very satisfied with the result he got. Of course, this is up to him at the end. And this is again a close-up of his results. You can see that he had about a gummy smile of about 8 millimeters, and this is the result that he got at the end, and he
Doctor,
was very happy
show us the
with what he got.
photo of the patient profile. For
Profile there.
result, yes.
Profile is there. Okay, you can see these are the natural tooth shapes that we use. Okay, with the natural texture, the natural zeniths,
Doctor, click
and
on it. Click on it.
click.
Yes. Yeah.
No, if I click, I go back.
Now,
You want
go to the final profile photo as a result of patient.
this is the final pro. I'm on it right now.
Yeah. Now it's changed. Now, yes.
It looks like it changes when I skip and then I play once more for some reason. Now you can see it well, right?
Yes. Yes. Yes.
Okay, so this is the final profile photo, as we said, and we can see the gingival healing that's around the final veneers that we gave the patient, right? And the result before and after once more of a smile, and the patient's facial photo also. So going back, let's have a look at the second case. Can you see the slide now, Wala? Can you see
No,
the slide?
this is the final result of the patient of the previous. Yeah.
Okay,
Now this
now
is the
can you
next
see the
one.
result?
Yes.
Okay.
No, this is the next
Uh,
one.
Next case. Okay, so
Yes.
this is one of the first Gummy Smile cases that I actually did. This was a case that we did in the membership and restorative dentistry program. Me as a supervisor with my fellow students, we were working. They usually work on full mouth rehab cases that they have to do from the beginning to the end, and they have to stabilize and then give the patient the prosthetics at the end. So this is one of the cases that we worked with, and this is one of the cases that we worked on and implemented digitally. So this patient came in, all these anteriors were fully broken down. We did root canal treatments, post and cores, and what you can see here is actually mostly cores and not the tooth structure itself. And after we stabilized the case totally, we then started doing the smile design. The patient has a gummy smile, as you can see. And we started to plan for the case. We started doing it a little differently here. This is our 2D smile design. This is the digital wax up, the video that you can see playing here. This is the digital wax up on Nemo, on software called Nemotech. And this is the digital wax up that we did according to the smile design that was done on the photo. So this case we did with my good friend, Dr. Amr Ikram. We started to discuss the case that we wanted to do the double crown lengthening guide, which is a guide that we designed digitally. It's the same guide that you guys saw on the past case with the vacuum form, but it's designed digitally according to the wax up once more. It's not done manual, and it is 3D printed. So I sat with Dr. Amr. We did the CBCT for the patient, and using the CBCT and the digital wax up that we have and the original STL of the patient, we bought everything on top of each other, meaning we superimposed all the images so that we can start to fabricate or design our crown lengthening guide. And what is beautiful, and this is the beauty of digital dentistry, that you can overlap everything 3D on top of each other. The wax up that we have already reflects to the 2D smile design that we did. So we don't need to bring in the face here because we know our limits and we know what we need to do exactly. And this is reflected by the wax up that's in orange. And the original STL shows us our gingival margins now, and the CBCT shows us the bone levels. And from there, we can start to see where our CEJ is, where the limit, our limit is while we are designing the case. And we also had another problem with this case, that the patient had very short roots. I'm going to exit and bring in this real close that you can all see. We had another issue that we really needed to detect where the composite is exactly and where the tooth structure is, so that we can attain a feral effect of at least 1.5 to 2 millimeters. And this was quite impossible to do intraoral. So we used the CBCT here to know exactly where our margins can be, and if this is going to give a good result for the patient and reasonable results for the patient. And we also had a problem that the patient had short roots. So we were able also to detect the crown root ratio, the minimal crown root ratio that we can attain, which is 1:1, to be able to give results for the patient. So it's not only seeing where your CEJ is. When we do the CBCT, you can see the CEJ, you can see where the soft tissue is, you can see the soft tissue level here, the gingival margin. Given that you have done this CBCT using retractors or cotton rolls, the upper lip is usually retracted in this area here so that you can see the gingival tissues. So you can see the gingival margin here. You can see where the bone level is. You can see where your mock-up is. You can see the new gingival margin that you want to attain after the crown lengthening. You can see the crown root ratio that you're going to get, and you can make sure that you have a definitive ferial effect all around the tooth, 360. So these are tons of diagnostics that are very difficult for you to attain just intraorally or just with traditional radiographs. Or with just the CBCT. You need the CBCT there, you need the mock-up, you need also the original STL of the patient to get all this information and to get and execute for the patient perfect results. What we thought of here, and this was actually Dr. Amr Ikram's idea, was why not fabricate two guides, because we had one limitation with the double crown lengthening guide. Double crown lengthening guide is just the same guide that I showed you, but it shows you, it's one guide that shows you where to remove soft tissue and bone, okay? So imagine placing the guide in, and then you do the gingivectomies, then you have to raise the flap, and you use the same guide to reduce the bone. But you have one problem, that the soft tissue, of course, has some thickness. So after you raise the flap and you put in the guide once more, it's usually not adapted to the bone exactly to show you your new bone level exactly where it should be. So Dr. Amr thought of another way. Let's do two guides, one guide for the gingivectomy adapted to the patient's intraoral scan, which will be adapted on the soft tissue, and a second guide that will be adapted to the bone after the patient, after we raise the flap. So this was, so that is more accurate. This was the first guide that was adapted to the soft tissue, the gingivectomy guide, and this is the second guide was adapted to the CBCT, because we already can detect the bone architecture from the CBCT itself. It was adapted to the CBCT so that when we raise our flap, it is adapted to the bone very well. And you can see also that we have here the festooning or the scalloping that we need, so that we can adjust also our bone architecture around the soft tissue, so that we can make sure that we do not or we have the least recession or adverse effects after the surgical procedure, and we have as many as accurate results as possible. So what's in green is the bone removal guide, and what's in pink is the gingivectomy guide. Well, you can see the slides clearly now, right?
Yes, yes.
Okay, so I'm not going to press play again, because when I do that, that's when it
It's
lags for
TikTok.
some reason. So this is this is during the surgical procedure. This is after we did the gingivectomies, and then we raised the flap, and this is after we removed the bone. And I did something a bit extra here in this part, is I actually reduced the teeth on the same visit when I was raising the flap, because the patient needed something temporary in position. And since we already have our design and we know what we're going to do later on, even if we have some changes in the soft tissue, we can change it later on in the finals. It wouldn't be a problem. And I actually took my impression. This wasn't a scan. I didn't have my scanner at that time. I actually took my secondary impression of the teeth while they were reduced, when the flap was raised, because there's no better retraction than this. We did not have, as you can see, we have minimal bleeding, and we were able to isolate, so we were able to get a good impression. Of course, the preps were done just after the gingivectomy, because the gingivectomy shows you your new gingival margin and where your finish line should be. And then we raised the flap, removed the bone, and because our guide was adapted to bone, there was no problem of using the guide here. It wouldn't be loose. And then we took our impression, and according to our design, we fabricated temporary milled PMMA restorations. PMMA is polymethyl methacrylate. Okay, it is a milled temporary block, and we designed it for the patient. This was the patient before. This is 3 to 4 days. Sorry, this was the day that we removed the sutures for the patient, and we placed in the temporary crowns for the patient. Of course, they were all post on course, so the patient needed crowns, not veneers. And we left the patient for some time for healing. And this is where we started to see magnificent results. And this is where I really believe that temporizing your patient to get optimal results is something that is a must. If you can see here, this is the day that we started just removing our temporary crowns.
PPMA.
Okay. And you can our PMMA restorations, and you can see I was just lifting the PMMA just a little off the soft tissue, and you can see the papilla height that we had attained and the healing that we got around these temporary crowns that we have, because they are very finely polished and well designed, okay, and well adapted. So we were able to get very good results for our patient. Which slide are we on now, Walaa? Because I can see that you still have the lag.
Yeah, DSD and Exocat.
Yes, okay, perfect.
Yes.
That's the slide I'm on. Okay,
Yes.
so as we can see here, you can see the soft tissue healing around the temporary restorations or the temporary crowns that we have. Then accordingly, we then took our final scan or final impression, and we copied our final restorations from the wax up that we had already showed the patient from the beginning. So this was our first design of the wax up. This is the 3D printed model that we use for the mock-up. This is our design on ExoCAD, which is the same as the preliminary design. These are our final ceramics on the model, and you can see the 3D staining glazing technique that we had used then. And the next slide, sorry, the next slide showing the final results that we gave our patient. This is where we went into quite difficulty here, because this is the problem that we have usually with patients, because the patients that we used to work on the program there were charity cases. And once we delivered for the patient the finals, then this is when all the oral hygiene went the other way around. She stopped brushing, she stopped flossing. So this healing, this perfect healing of the photo of the healing that we have here, we could not get, unfortunately, for the finals. But this is the problem when patients cannot attain good oral hygiene.
Yes,
Okay,
sure.
so going to one more case very quick, so that we don't take too much of your time, even more than that. Can you see the slide of the new case, Wala?
Yes. It's a new
Okay.
case.
Okay, so another Gummy Smile case once more. Let's to show you just the workflow, or the digital workflow that we use. We did the smile design for the patient. We did the digital wax up also for the patient. This was also done on Nemo. And then we did the mock-up for the patient, showing the patient the mock-up before and after. Patient was very happy with the results. We could see the results on her face and how it looked on her face. And from there, we then copied this for our final restorations. We did crown lengthening for this patient. And you can see here that the design on the CAD software is exactly the same copy as the 3D mockup, and this we discussed last Thursday. And you can see the frontal views are all the same, and the side views are all the same results for the patient. And at the end, we were able to give the patient these results that she liked very much. And we also were very happy with the results we gave her. If you look at only this photo intraorally, and usually I get this comment a lot, you would say that the teeth look a bit too long, right, Wala?
Yes.
But when you look at the patient's facial photo, you will not say that. Okay, so it looks on the patient's face, because she has a long face, we gave her 75%. Not
Doctor,
80%, which is acceptable,
this
because
is
our average is from
wow.
75 to 85. Yes,
This
Wala.
is wow result. This is wow result.
Thank you
Right?
so much. Okay. And
Amazing.
this of the patient also, her before and after. And this is where I really start to love, and I have passion for dentistry. And this is when I feel that we are actually always able, or we have the ability of changing our patients' lives. Look at how she looked before, and look at the confidence she has in this photo of the after we had finished her teeth. She had changed totally. She changed the way she changed her hair, she changed her makeup, her personality totally
She changed
changed.
everything. Yes.
She usually she used to come into the clinic very shy. Now every 2 to 3 weeks she passes by, because she wants us to take more photos for her in the studio. She works just near our clinic, so she always passes by every 3 to 4 weeks,
I
wanting
need
to
to
take
come.
more photos again. If you have
She will
thousands
be a
of
blogger.
photos of her.
She
Excuse
will be a
me.
blogger. She wanna be a
Yeah.
blogger now.
And actually, after all that, 6 months after we finished, she got married. So this was
Ah,
something that we
this
were
is
happy with.
this. Yes. This.
So this was
As
another
a,
change in her life.
yeah.
I don't know if this video is going to
Doctor,
play or not, but I'm going to try
Doctor,
to
you
play it.
can.
I hope that you
Yeah.
guys can see it. Okay, this
Yeah.
is the video of her motion after we did the crown lengthening procedure. I hope that you all can see. Can you see the video, Wala?
No, Doctor, you can
Uh,
play it. You can play it as it. Yes.
I
Double
don't
click.
know. Okay,
Yes.
there, and
Here.
they won't play together.
Yeah.
I'll just play the after. okay, so that you guys
Yeah,
can see.
the happiness. This named happiness.
Yeah. So we're very proud of the results we were able to give her. Uh, I'll just show you one more case because this is an important case actually, so that we can understand the diagnostic concept that we talked about, the 5 questions, even more. This was a case that we did as a live demonstration in part 2 of our mastership
DSD.
program,
Yes.
where we treat clinical cases live in front of everyone. And you and all our audience treatment plan the case with us, and they join in every single step. And we do all the clinical steps from the beginning to the end. So these are one of the 4 cases that we do. We do a gummy smile case, and we do a full arch implant case, and we do a veneer case and an occlusion case. So was one of the gummy smile cases that we did in part 2 of our course in Berlin about 1.5 years ago. This is the book that I was talking about as a reference, 5 Core Questions for Evaluation of Gummy Smile by Bill Robbins. It's a magnificent book. I think you should all try to read this book. It's very informative. And again, the way that we diagnose,
The
first we'll
five
go through this
criteria.
very quick. Okay, so the first question is the facial height, and we found that the patient had vertical maxillary excess once more. So he either needed orthognathic or Botox. And then the lip length was normal, lip mobility was normal also. And then we started to look at the gingival line, and this is very important. We found that it was curved, meaning that the gingival margin of the laterals and the centers were at a lower level than the canines. So we diagnosed the patient as having dentoalveolar extrusion. So he would either need crown lengthening or intrusion. Okay, and then so this is a totally different diagnosis than the past case. And then tooth length, it was measured as 6.5 millimeters, and we diagnosed the patient as having now gingival hyperplasia, and we needed a gingivectomy or aesthetic crown lengthening, or sorry, a gingival crown lengthening. And then the last question: can you feel the CAJ within the sulcus or not? And we found that we could not feel the CAJ within the sulcus, so the patient has altered passive eruption, so he will need also crown lengthening. So our final diagnosis and treatment plan was intrusion of the centrals and the laterals, gingival and osseous crown lengthening, and Botox to be able to get over the gummy smile that the patient has. So this is where it's important that you always ask yourself the 5 questions and then reach your final diagnosis and treatment plan. And if you look carefully here, this is a slide that I wanted to show you all. This is when you take the CBCT with the lips retracted. You can see where your soft tissue level is. You can see where the CHA is. You can see where the bone level is. You can also diagnose the crown to root ratio. You can also put on this your intraoral scan and see where the gingival margins are more accurately. You can also overlap this with your mock-up and know where your new level is. Take all your measurements and then reach a final diagnosis. To me, a CBCT is a must with any gummy smile case because it gives you diagnostics that you cannot take intraorally. You're able then to design and fabricate a guide to use for the surgical procedure without thinking of all these measurements during the surgical procedure, because this is usually where fault comes in. It's not always, we're not always in the perfect fit. And always think of this when we are doing any clinical procedure. There's sometimes where you're tired, sometimes where you can't think clearly, sometimes when you're not in such a good mood, but your patient is scheduled and you have to do the surgical procedure. And that is where the guide comes in as accuracy, predictability, giving you the results that you will never able to get with your own eyes and with your own hands. I'm not I'm with that you have to have clinical experience, of course, to get the best results, and you will get even better when you have a guide that you're working with. Okay, so accordingly, our treatment plan was as follows for the case. As you can see, we did the smile design for the case. This was our new gingival curve and our new smile curve. And look where the teeth are, where the incisal edges of the centers and laterals and the canines are, okay? And where the gingival margins of the centers and laterals are now and canines, and where the new gingival margin is. So we started to diagnose the case. And according to this new smile curve, we understood the amount of intrusion that we could use for this case that would decrease a part of the Gummy Smile and also adjust my smile curve, because we also have the diagnostics from the video and we can see the rest positions of the centrals. Okay, so we understood that we will do 1 millimeter only of intrusion, and we will need about 2.2 millimeters only of crown lengthening, because this is where our CAJ was. So the rest of the 2.3 millimeters would be by the Botox or orthognathic. So as it is a multifactorial case, and this is usually the types of cases that we see that have gummy smiles, we are also, with the smile design process, able to evaluate how much of each procedure we need to do to give our patient the perfect result. So it's not only diagnostics, and it's also the full treatment plan. So from there, we did the wax up or the digital wax up in front of all the audience, and they did it with us also. And this is part of our training on their laptops. And from there, we started to fabricate or do a mock-up for the patient. This is the photos of the mock-up. And a lot of people ask me this question. You can see that the mock-up is not covering all of the patient's teeth. There's part of the incisal edge that you can see. So we only colored this small part of his tooth that shows with a black marker, so that you cannot see it during the photos. And this is the before and the after of the mock-up that we showed the patient. Patient loved the mock-up, and from there we started to do the surgical procedure. Here we used the vacuum formed stent once more, just because we were just going to do gingivectomies for this patient, and we fabricated it on the printed model. And for the crown lengthening procedure, we did a totally different procedure, or we used a different procedure here. I'm going to need to play this from the outside so that you can all, sorry, just a second. This is quite, I don't know if I can it play? Well, this way it's not playing, but it's okay. I will show you later on. Wala, are you with me?
Yeah,
Wala,
Victor, I'm
can you
with
hear
you.
me?
Yeah.
I'm trying to play from here
Yes,
itself,
double.
but I'm not able to.
No,
Double
Doctor,
click.
double click on it. Yeah.
There, yeah, perfect. Okay.
Yes.
So let me go to the first video first. Okay. So this is me trying in the guide. This is something very important with any guide that you have fabricated. You need to check its fit first. Okay, this is very important. So now I'm trying to fit in front of everyone. And we are making sure that our gingival levels are, we took bleeding points with measurements first, and then we put this in to make sure, just to double check that we are at the same level, because sometimes if the guide is too tight, it will push the gingival margins to a more coronal position. Right? And okay, and then what we use here is a special. It's like a piezo, but it's an ultrasonic machine with a special tip that was patented by Master Paulo Cano from Brazil. It's a special tip that you can use that for flapless removal of bone. But given that the bone level is thin and not thick, and it only removes the bone and will not traumatize the soft tissue or the tooth structure itself. So this is using the CV Dentist machine. And this is me going beneath the sulcus, and we have a 3 millimeter marker that shows us the extent that we should go to. And you start to feel resistance as soon as you are removing bone. And then when you have removed enough bone, the resistance is gone. So you know that you are now removed the correct level of bone that you need. Okay. Just to show you that so that you can be more familiar. This is the machine itself. It's called CV Dentist from a company called Dent Surge. It is available in Europe, and it is available also in Brazil. I don't know if it's not in so many areas in the Middle East, but I think you can get it or try to search for it. You will find it. This is after we did the gingivectomies and the crown lengthenings. One of the main advantages of this machine is the amount of bleeding is minimal, and you can actually restore the patient if you want at the same day, especially the cases that have very thin label bone, not thick bone. This is a very useful equipment, and you can also use it, use a piezo. Another case, the sister of the girl that we saw in the past case, and this is a different type of case. That's why I wanted to show it to you all. If you look at her video here, of course, these are the two photos that we take to evaluate the case. This is the video with full motion that the patient is giving us so that we can see the extent of the gummy smile. Very shy patient, actually. It was one of the cases that I showed that on the emotional dentistry part on Thursday. Anyway, on evaluation, we found that the patient again has vertical maxillary excess but minimal. The difference is about 5 millimeters, which is not such a big issue. And when we completed all our questions, we found that she has lip mobility of 11 millimeters. That means she will need Botox, and we could not feel and she had 6 millimeter length of the centrals. So she will need gingivectomies, and her CEJ also could not be felt within the sulcus, so she had altopassive eruption, so she will need crown lengthening and Botox. And again, with the CBCT, the diagnostics that you can get are magnificent, showing the soft tissue is very clear here, and where the bone and the thickness of the bone that we have, the thickness of the soft tissue also that we have, so you will be able to detect biotype, and aligning this or registering this to the intraoral scan and to the mock-up is where the 100% benefit you get from digital dentistry. And here the smile design once more, showing giving us our new incisor levels, and accordingly our new gingival levels according to where the CEJ is from the information we got from the CBCT, showing that we will need crown lengthening 2.5 millimeters and Botox of 4.5 millimeters. So you are able to some extent adjust your dose so that you get that much of extent, so that you don't get a paralyzed lip. And again, registering everything to each other. This is the digital wax up that we did for the patient. This is when we started to implement a totally different concept, and this is a concept originated by Dr. Amr Tuhami, and myself and Dr. Islam Asim helped him with documenting cases and implementing the idea on different cases, and we adjusted the concept together. So this is when we took a face scan for our patient, and we fabricated a guide for the Botox administration for the upper lip. And the main reason for doing this is, again, to be predictable, to know the exact position that you need to inject for the patient, the angulation that you're going to use, the depth of the insulin needle also. And this is for repeatability, because every 4 to 6 months, the patient will need to administer this once more. So it's very easy. I'm not a Botox and fillers expert. So, and I'm the one who gave the Botox for the patient. So all I needed is to put the guide on her face and just put in the needle and put in the doses that I was told by Dr. Islam Asim. And from here, you can see the before and after for the patient. And I hope that you all enjoyed.
Wow.
And the lecture was beneficial. This is my contact info. If you need to contact me at any time, please take a snapshot of this photo if you're interested in contacting me. That's number one. And our last slide of the day. As we said, we all belong to a bigger family, which is Digital Dentistry Society. And we would love you all to be part of this great family, because it's all about sharing knowledge with
I
each
will do
other.
that.
You can all take photos of this slide, and you can scan this barcode, and you will be directed to the DDS website. And from there, you can register yourself as a free member with no cost at all. And then there are benefits for that. And there are a few videos or webinars that are for free members. If you're even more interested, you can go to the active membership, where there are even more and more advantages to that, and you have access to our full digital online platform from all the experts worldwide. So this is an opportunity for you all to use the time that you have, that you're at home right now. And if you are interested in digital dentistry and the digital concept, to get more into that area. I don't know how long I've been online now. Well, I think what 2 hours
Yeah,
or something.
around, yes.
Yes.
Really,
So
it's very interested lecture.
if anyone has
So
questions, I would be more than glad to answer. So
we
do we
have,
have questions, Wala?
yeah, we have many questions. Um, Doctor, please, regard,
Hmm.
Doctor, go to the webinar I sent for you, the link, and you can read everything now. So go to
Okay.
yes, Doctor, please, regarding the motivational cast, how much space is needed for temporary material so I take care of it during designing?
Do you do the it's not something that you measure. If you look here, it's the most important thing is that the mock-up just covers the tooth, and you can see this on the software. So we don't measure. Look at this case. This is a minimal part of the tooth that you can that is visible, and I know that this is going to happen. And usually the bisacrylic just spreads a little and covers that part. You just need to bring the teeth outside so that they just cover up the whole tooth. There's no measurement to this. Okay.
Mhm.
uh, as minimal as possible, because the more you go out, the more bulky it's going to be. What's most important is that it covers the teeth so that you can
Yeah.
motivate.
Dr. Abdullah, he said Botox gives only temporary results. Yes,
Yes,
he mentioned that.
that's
Yeah.
true. Yes, that's true.
Doctor, we had some questions in the beginning of your presentation. Um, as I told them, they must ask after, not before,
It's
because
okay.
yeah, because it's more than 120 um, comments.
You're fast, Wala.
Yeah, yeah.
Take your time. If anyone has
Uh,
questions, please type. I can't see the questions. Let me go to Dentalinium, right?
yeah. Dentalinium and Doctor, now we are sharing to DSD team members Egypt study group.
Study group. Yeah.
Yes, they are sending for you. Thank you, Doctor, for your amazing as usual.
Thank you for your
Yes,
time, everyone.
yeah,
Really, thank
they
you.
are appreciating you.
If you have any
And
questions at any time, I would love to answer them. Wala, if you want me to answer the questions later on by
yeah,
message
yes,
or with a comment, I don't mind.
yeah,
So you are
Doctor.
you're the one who's directing me. So tell me what you want, and I will do
Thank
exactly what you need. Okay?
Thank you very much, Doctor. Uh, why use two surgical guides for crown lengthening, not one guide for
Right.
both
So
of tissue angle?
this was the idea was originated by Dr. Amr Ikram, a good friend of mine. We have one, not saying that the double crown lengthening guide is not good, it's perfect, and we use it a lot and we use it worldwide. And the double crown lengthening guide idea was originated by Christine Coachman and his team. Uh, the problem with the double crown lengthening guide, which is a guide, one guide for the gingivectomy and crown lengthening at the same time, is after you raise the flap, the guide is a little loose because it's not adapted to the bone. Because there's soft tissue there's soft tissue thickness, right? And the guide was fabricated originally on the intraoral scan. So what we did is we did two guides: a guide that is adapted to the intraoral scan, which is the teeth and gingiva, and another guide that was adapted to the CBCT. So it was adapted to the bone. So after you raise the flap and you put the guide in, it will be adapted to the bone accurately, and you can detect exactly where you need to remove the bone when the guide is still in place.
Mhm.
So it's just
Doc-
something extra.
Yes, Doctor. We have another question about lip mobility. what are the criteria depending on mobility measurements? In other words, when can I make a crown lengthening and when can I make a Botox?
Ask yourself the 5 questions, then you will know when you can do Botox and when you can do crown lengthening. That's the whole point of the whole 5 questions. Okay, so according to the questions you ask, then you get the diagnosis, and then you know when to need Botox. You need Botox
Treatment.
if you have only a hypermile lip and vertical maxillary excess. You need crown lengthening when you have autopassive eruption. It's that easy.
Okay. Doctor, do you think Botox can give us needs, yeah, or around 2 to 4 millimeters?
I'm not an expert in that part, but yes, I have seen cases that up to 4 millimeters. Yes.
Doctor, the last question. Can PRF be used as fillers?
No, I'm not the person to ask.
Yes.
Not my specialty. You
Yeah.
guys, if you can text Dr. Islam Asim. He's a good friend and one of the experts in Botox and fillers. He's very this is his expertise, one of his expertise, and he's very good at it. Direct your questions straight away to Islam. He's a very helpful person. I'm sure if any of you message him on Messenger, he will answer back straight away.
Doctor, after 2 to 3 days, we will have a lecture with him.
Perfect. So you can
Yes.
ask Islam that question when he's online.
Really, Doctor, appreciate. Thank you very much for your nice, fully informative lecture. Really, I'm very happy. I'm very proud of you. It's amazing to be with you every time. When in, we were in many places. We traveled to
Yes, we've been through a lot
Jordan,
together, Wala, and
yeah,
it's been a lot of
Baghdad,
fun actually. And if
yeah,
we hadn't been, we've been through a lot of hard trips actually. And you
yeah,
don't have
really.
to say that online now, but if it wasn't that we were together, it would have been a disaster. We
Yeah,
actually there was a trip that we spent 2 days trying to get to that place, and
two
but at
days
the end
we
it was
reached
a
the
perfect it was a
place. Yes,
perfect experience actually.
yeah,
And
really,
it was
really.
only experience. It was so good because the company was excellent. And thank
Yeah,
you, Ala, always for
thank
being
you.
always so optimistic and helping us all through these hard times. And thank you all for attending. And it was a pleasure to be with you all.
Thank you, Doctor. Hope everybody stay home and be safe. Everything will come to your home. Assalamu alaikum from Wala Al Mola. Thank you, Doctor. Inshallah, see
Thank you.
you soon again. Bye bye.
Bye bye.